not require prolonged periods of immobilization or non-weight bearing. The clinician should be guided by the athlete's symptoms. If they are very symptomatic, a short period of partial or non-weight bearing in a boot/cast, especially for second metatarsal neck fractures, can be useful. A graded rehabilitation program can then be followed. Injuries require specific treatment programs, including surgery. Posterior tibia. Stress fractures involving the posterior and medial border of the tibia are relatively common. It is also important to consider the other causes of shin pain in athletes. These include chronic exertional compartment syndrome and medial tibial stress syndrome, shin splints. X-ray of third metatarsal stress fracture. X-ray of fourth metatarsal stress fracture. Athletes generally present with posteromedial shin or calf pain. Occasionally, they describe sustaining a calf injury, rather than the characteristic pattern of pain associated with bone stress. Localized tenderness, in a relatively focal area, is the key examination finding. X-rays should be ordered and may demonstrate periosteel new bone. MRIs can show marrow edema, periosteel reaction, and possibly a sclerotic fracture line. CT scans may be appropriate to clarify the degree of bone injury as a basis for rehabilitation planning. Management. Load management and strengthening, with subsequent gait review and retraining, are the key modalities. To minimize recurrence, the offloading period does need to be relatively protracted in some cases. The diagnosis of this injury can often be delayed. As a result, there is often delayed union and recurrences. This is not something that is well described in the literature. High-risk stress fractures. A navicular stress fracture is a good example of a high-risk injury. Targeted imaging studies and treatment are advised. Navicular stress fractures of the tarsal navicular are not seriously difficult to diagnose and treat. The middle third of the navicular has the least poor blood supply. As a result, this is the region where most navicular stress fractures occur. Athletes present with a gradual onset of activity-related dorsal midfoot pain. The pain can be very diffuse and difficult to localize. As a result, the diagnosis is often delayed. Key findings are of tenderness over the navicular, especially at the end spot, dorsal aspect of navicular between the tibia's anterior and extensor hallucis longus tendon. Risk factors which can be identified on examination include decreased ankle dorsiflexion, foot hyperpronation and tarsal coalition. X-rays are generally normal in this condition. Bone scans and MRIs are sensitive in the diagnosis of navicular bone stress. Our practice is to make the initial diagnosis with MRI and to then complete a CT scan to define the injury. CT remains the gold standard for the diagnosis and staging of navicular stress fractures. When the CT scan is normal, or when there is only a subtle breach in the dorsal cortex, the injury is less prone to delayed union. When the fracture extends into the body of the navicular, or involves two cortices, the prognosis is more guarded. Non-weight-bearing cast immobilization for 6 to 8 weeks is the treatment of choice. This is true even when there has been a delayed diagnosis, where clinical symptoms may have been present for weeks before diagnosis. In these cases, non-weight-bearing immobilization can result in successful healing with an 80% return to sport rate. Surgical fixation is indicated when there is non-union, delayed union, or if there is significant separation at the fracture site. Screw fixation is used, with or without bone grafting. It is important to ensure that the athlete also remains non-weight-bearing for 6 weeks post-surgery. Clinical union is achieved when clinical symptoms resolve, including pain with provocation, e.g. HOP tests. In some cases, radiological union can be confirmed by CT imaging, however, this can also be misleading. It should be noted that increased signal on MRI is maintained after radiological union for up to 6 months. If tenderness at the end spot persists, then a further 2 weeks of non-weight-bearing immobilization is indicated. X-ray of navicular cone stress fracture with screw. Fifth, metatarsal stress fractures involving